I'm Todd Brown. I'm a professor of medicine and epidemiology in the Division of Endocrinology, Diabetes, and Metabolism at Johns Hopkins University. Yeah, they are. So one of the concerns that people have is interactions with HIV drugs, and we don't know of any interactions with GLP-1 receptor agonists and antiretroviral therapies, which is great. There are a few things that we do need to be concerned about with GLP-1s regarding the adverse effects. We think that they're probably the same adverse effects in people with and without HIV. So the GI side effects are the most common and treatment limiting in about 10% of people, and probably in people with HIV, it's about the same. One thing that we're concerned about is the effect of these medications on muscle and bone. So as people age, muscle mass decreases and bone mass decreases. And we think that this might be more pronounced in older people with HIV. With these medications, which cause profound weight loss in some people, and in most people, therapeutic weight loss, there's not only a loss of fat, but a loss of muscle and bone as well. Now, it's generally seen with all weight loss therapies, whether it be bariatric surgery or behavioral measures, but some people may lose more bone and more muscle, and we need to be looking at that carefully as we think about the risks and benefits of these medications in older people with HIV. So I think the real indication when these drugs really first started is with diabetes, and these are great diabetes drugs. Particularly people who have excess adiposity, excess fat. So that's the population where I started using these drugs, and they work really well. The added bonus, which we didn't know when we first started using these drugs, is that they decrease cardiovascular events. So we know that in people with diabetes, cardiovascular disease is the biggest killer. So if we can give a drug that decreases glucose, that has an impact on weight, and also decreases cardiovascular events, that's really a big plus. So in people with HIV, I prescribe these drugs routinely in patients with concomitant diabetes. In people without diabetes but have excess adiposity, these drugs also can be really helpful, and I prescribe these drugs in that setting as well. There are other potential indications. We think that in people with HIV, there is increased systemic inflammation and immune activation, even with suppressive antiretroviral therapy. We know that these drugs have a profound effect on systemic inflammation that's independent of the weight loss and independent of the glucose lowering. But we really need to study this in people with HIV to understand whether or not this effect on inflammation is true in HIV. What dose do we need to use this? Can we use lower doses where you won't get the problems with muscle and bone? Maybe you don't get as profound weight loss. Perhaps you can use them in people who are not diabetic and who aren't obese. So it's important to study these in this separate population. Yeah, I mean, the interaction that you might think about is what I was mentioning before regarding chronic inflammation, because we know that this is such a hallmark of treated HIV disease. But there's not to date, and really we're at the beginning of trying to understand these drugs in this population. Today, we don't really have great evidence that these drugs have any excess benefit or excess risk in people with HIV, but it's really we're just at the beginning of trying to understand this.
Don't forget to like and subscribe so you can catch everything from Infectious Disease Special Edition.